But my problem is when it's ignored or normalized to be like, you're just so bad that you just can't go to school and you're throwing up. So just take the pill. Like, people don't even know that that's not normal.
No.
Number one, you need a healthcare provider that listens. Like, what's the best diagnostic tool for endometriosis? Listening. I think the most important group is people who maybe don't have a pathway to a family, but want a family. So someone who's like, I definitely want kids. I'm 29, 28, and I'll always tell stories, including my own, where I was told the exact words were, you should have done IVF yesterday based on your AMH. It wasn't true for me.
Okay, hi off the charts. It's me, Dr. Parmar again. Thank you for tuning again to the podcast. It's so much fun. Today we have Dr. Alana Shaw. Hi, Alana. She's in one of my besties for a couple decades, which is crazy to say. We went to school together and gravitated to her on day one because we both thought everybody else was weird. And we're just like, oh, you're judging everybody else too? I'm going to stick with her. It was a long story there. But so we go way back, and I think she's the smartest person I've ever met in my life. And I really wanted her to be on the podcast because she does a lot in the fertility world, way more than that, in the perimenopause, menopause, and beyond world as well. But there's just so much about fertility these days online. I follow a lot of reproductive endocrinologists and fertility experts. And I was like, I want to, even though this is my world too, but she's Queen Bee, I want to ask Dr. Shaw some questions so that our audience gets to hear her perspective on all of the hullabaloo out there about what's happening with IVF and fertility assessments, et cetera, et cetera. And I want to talk to her a little bit about what she's doing at her clinic called Mint Integrative Health in Vancouver as well. So welcome, Dr. Shaw. Thanks for being here.
Yes, Bobby. It's really nice. I always am so flattered when you say those nice things about me.
You deserve every word.
Thank you.
So you're in the fertility world, and right now, I don't know if you perceive this because you're not really an online person, but do you see a lot of people coming in and asking you in your own clinical experience, a lot of new things or a lot of updated things that they feel like they're being told online that you have to kind of either combat or reframe? Are you noticing anything differently?
I'm not online.
Yeah,
very much so.
same. I did that already.
But, I do get my patients that come in and have questions just generally. I think, if anything, it's just more awareness, which isn't necessarily a bad thing. I think is that there's more people being more aware of specifically things like AMH and wanting to get an idea of, where their fertility's at. And so I think if there's any kind of education that I'm doing more, it's around what is AMH? How do you assess your fertility? That kind of stuff.
That's so interesting because I am online and I just see so much. I screen grab things and I send them to you being like, oh my God, this person's saying this, that, and the other. And a lot of it is, for me, misinforming people. And but you're not necessarily seeing a lot of people come in different than before being like, I want this. And you're like, where do you get that from?
Maybe supplements.
Oh,
I think there's a lot of supplements out there now, like branded formulas and things like that, where people will be like, I'm on this new fertility formula. And I would say that's probably accelerated in the last couple of years.
I think there's a lot of pushback against that, especially from IVF centers, to be like, supplements don't do anything. I see that a lot. There's a doctor named Dr. Lucky Sakon. I follow her. She's incredible. Oh my God, follow her as well. But she, in her expertise, also has opinions around supplementation and essentially says the only things you should ever be considering are vitamin D and CoQ10. Maybe. There's always this maybe. How do you feel about that? I feel like you're in this incredible position to coach people on what they're supposed to be doing in your experience, but also by the evidence. How do you feel about when you hear experts? Obviously, these are very important people in our world. They create a lot of families and help people. But how do you feel about that's a perspective that is very strongly suggested to people you can't do anything to support your fertility?
I mean, the naturopath in me, like at my core, is alive and well when I hear those things. I disagree fully. Like, I agree to some capacity that there, these fertility formulas that are like, take this supplement, it will make you fertile. Ugh. I agree 100% with that. That I think, from a very superficial level, there's not like a magic thing that antioxidants are going to rescue your fertility. But I do believe in um, what we do as like naturopathic physicians, and where we have such an important role in fertility, is that if you target your treatments towards what the root cause is, and that's sort of like the, philosophies of what we do, is they're all trying to get the root cause and figure out like where things are out of balance. So if you understand a bit better why someone's having trouble getting pregnant. Right. So for example, you had insulin resistance, like a fertility formula with CoQ10 and, L-arginine and vitamin E for your lining isn't what you need. You need things like maybe inositol, maybe things to help with blood sugar. You maybe need to lose weight. You need to figure out like where are nutrient deficiencies. So if someone's iron deficient, which, you're doing such great work with that, but like, yes, iron's a supplement, and that's going to help. If they're not sleeping and they need help with like sleep support, and that's going to help with their overall health. So I think on a deeper level, you can use supplements to target where the root cause of what's going on is. And if you just blanket everyone with infertility and say, here's an infertility supplement, I agree that doesn't exist, but I do think there's a role for.
I think that's what's happening, but I think there's something else. It's like you want to help your ovaries be less inflamed, or you want ovarian support, and that there may be something you could take to help with inflammation, or not even across the board, that like women with PCOS could take this thing to help in this way, or women with endometriosis could take this thing in this way. It seems like there's a lot of specialists who are voicing saying nothing you do will work, even in those narrow verticals. But you believe differently.
I see differently every day.
I know you do. So do I. That's why I asked.
Yeah, I mean, I work a lot with fertility clinics in the city, and I don't think that's what a lot of them say when it comes down to it. But I think they just, maybe it's not their world.
Yeah.
And if you're looking online at some formula with a proprietary blend of 8 different herbs, yeah, I question that too.
Yeah. Okay.
But if it's, using the best available evidence we have about, more naturopathic and mixing it with sort of pharmaceutical treatment plans, then yeah, I disagree.
I can't wait for you to read The Lucky Egg if you haven't already.
Yeah.
Have you?
No, I read it. I bought it.
It's just, she's one of the doctors who I think is like at the forefront of this. And, all due respect, like I think she's incredible and I applaud so much of what she does, but she represents this sort of pushback against what I see happen day to day in my office, and that I definitely know that you see happen in your office.
Yeah.
And I just want people to know, like, there's this, it's not all true just because a doctor in that lane says like there's nothing else that might be able to support you in like a broad stroke. Don't find yourself caught in that, because you might be unique and different in a way that there are things you can do to make a difference with your specific circumstance. I think that's what you were just saying, right? Like it's totally based on what you're going through.
Yeah. Those doctors are so incredibly like talented at what they do. Like they do IVF. Yeah, exactly. And I have so much respect for what they do. How could they possibly also be experts in the latest research in nutrition, in supplements, in like lifestyle management? Like how could they do it all? So I
don't think they can. That's the thing. I don't think they can. That's why people like us are needed and people like you are needed.
Yeah. And I think, I don't obviously personally know her. I think it would be great if she found someone she trusted to lean on. And there are a lot of doctors, especially in Vancouver, that collaborate with people like us and trust what we're doing and working together, and trust that we also aren't doing anything that's going to, work against what they're doing in true and complementary medicine.
Yeah. How do you feel about assessing fertility? I know this is a mission of yours. I know that you
Yeah.
want to really explore expanding fertility understanding for women and people across the board. What does that mean to you, like to assess your fertility?
Yeah. I think it means like two things. One would be in my ideal world, everybody would do some kind of assessment um, before they get to 35. So we would avoid the scenario where you have the 16 or 18-year-old that goes on the pill, stays on the pill for 10 to 20 years, and then says, I want to have a baby, stops the pill, and is like, oh, what's happening?
Right.
I would love if people would check in on their fertility, maybe in their 20s. Like, anyone who has a concern, check in, but definitely in your 20s, your early 30s, just to help you plan, but also so that you're talking to somebody to understand what fertility is and understand if you have any signs that maybe you should look into this further.
How young is there too young for somebody to be like, I want to know this just in case in the future I'm interested? Is there too young to assess your fertility?
I don't think so. I think it depends. Assess, like, do they need to go through a full workup? Like, no, but if you have really painful periods or you have amenorrhea, should you talk to somebody about this? Yes, instead of like just going on the pill and not. I would say by assess, I would say that would be an important place where maybe that's not happening because we don't have as good access to gynecologists here, is that a lot of those patients might be managed by just saying, well, your periods are really painful, so here's the pill and, you know, take it until you want to get pregnant.
Do you find that this is a common experience where women are asked, are you planning on conceiving soon? No? Okay. I'm just going to cover up what you're experiencing.
Yeah, 100%. 100%. I'm not saying that's necessarily a bad thing.
Yeah.
Because, so for example, with endometriosis, it would be like maybe a really great idea to get a progestin IUD so that you can live your life and also treat the endometriosis to some degree or contain it with the progestin, local progestin. But my problem is when it's ignored or normalized to be like, you just have like your periods are so bad that you just can't go to school and you're throwing up. So just take the pill. Like, people don't even know that that's not normal.
Yeah, right.
And then they come in at 35 because they want to get pregnant. And then for the first time, they're realizing, oh, shoot, maybe I have something that may affect my fertility. And then they're looking into it. And then maybe we do a thorough fertility assessment. And then they're realizing that, you know, where they may stand with IVF success and realizing like, oh, I'm doing this way too late. I should have done this in my 20s.
Or that they don't even realize that they might need assistance to help them conceive, because like what you're saying is nobody helped identify why they were experiencing some of the signals that their body was giving them that something was maybe at some point going to interfere with their ability to conceive as easily as the average person.
Yeah. Yeah.
Okay.
Yeah.
Like, where's the gap? Is the gap that we just in our system don't have the capacity to ask this question? It's not standard of care to ask the question like about your fertility and to like figure out what's actually going on with you. What's the missing piece?
I don't know. Because I think it probably is a lack of access to specialists. I think in other countries, what I hear from a lot of my patients that come to Canada is that you see a gynecologist every year. And so they come here and they go, what do you mean I'm not getting my women's wellness checkup? Like, in my ideal world, everyone would come in every year and get like a full screening.
Yeah, a lot of people get that. Like the Turkish women say this, the Brazilian women say this, the Eastern European women say this. There are definitely places in the world where you kind of just like walk into a gynae and then they're gynae. And so they're just like, okay, well, I'm going to do my thing.
Yeah. And they have pelvic ultrasound as part of that assessment. So for me, I like, that's why I love this tool, is because for some people, part of your just like, let's check in. And you're like, oh, did you know you have like a 4 centimeter fibroid? And you may be able to identify things that they may want to know before, because let's say you're 34 years old and your doctor says try for a year before you come back to me. You're like, why am I not getting pregnant? You may be able to figure out that, or give them a clue that like, oh, hey, you have fibroid. Don't wait a year before you go ask for help.
I also find it so fascinating, the idea of a fertility assessment, because before women, we've been almost doing this for 19 years. Great, so crazy. Oh, wow. Or wasn't our 20th year next year? Next year, 2027.
Yeah.
And I used to be like, oh, okay, well, have you been trying? It was a year to try, and then it kind of changed to 6 months to try before you assessed a person, where you did like blood work, or you did, and we kind of just did anything, And then you'd be like, oh, I'm going to do basal body temperature charting with this person, and I'm going to do LH strips and that kind of thing. And then it's evolved over time where it's gone tighter and tighter. And now I feel like it's flipped to, before you start even trying, do something. What is that something that a person should do before they start trying? And like, is that a thing for you?
Yeah, I would say talk to somebody, talk to a healthcare professional about your periods, so that you can find out, is there anything about your hormones or your cycles that makes someone think like, maybe you have endometriosis, maybe you have PCOS, maybe you have a fibroid.
Which a lot of people do. A lot of women don't realize that endometriosis and PCOS are not like 1% of the world.
It's like 10 to 20.
Yeah. A lot of people have these problems. It's not rarities that you're just like, oh, of course it's not me. A lot. That's the point.
So you would talk to someone screening for those things.
Yeah.
And then I think you would, depending on where you're at, like I think pelvic ultrasound plays an important role for that. I think like general health assessment, like get on top of any kind of thyroid issue you have, autoimmune issues that you have, mental health issues that you have, like make sure that you're optimizing your health. And then when it comes to planning, it would be things like AMH, antral follicle count, which are two tools that we can use to assess what's called ovarian reserve, which I want to be very clear that it doesn't assess fertility per se, but it helps you plan your timeline for family planning, I would say.
What do you mean it doesn't assess your fertility?
I would say like a low AMH does not mean infertility.
What is the AMH, and you said 3 things there that we have to talk about. AMH as a test, antral follicle count, and pelvic ultrasound. Let's start with pelvic ultrasound, because I'm sure that's going to be like, wait, I'm doing a what? What is like, what's a pelvic ultrasound, or what does it do to help a person in this scenario where you just pick?
So we use ultrasound. It's an endovaginal ultrasound, so internal ultrasound. Doesn't need a full bladder. I guess that's the bonus of going internal. But by doing that, you get closer to the ovaries, and so we can get a really good view of the ovaries. So we can screen the ovaries for things like cysts, like other kinds of growths, like maybe like if there's any endometriosis on the ovaries, we can sometimes see that. We can look at the uterus to get any idea if there's anything like fibroids growing or something called adenomyosis. You can sometimes see certain kinds of like shadowing. And so, what we do is not diagnostic. It's certainly a screening tool where we can look and be like, hey, there's something there that maybe looks like you should get this looked at. Like, go get a diagnostic ultrasound so you can identify what this is.
I think it's so important. I think it's one of the best things in the world because, and I'll explain my rationale and then Dr. Shaw can comment on it. So like there's up to 20% of women have endometriosis. One of the ways that shows up is painful periods. So like, what is a painful period? A lot of women are like, of course I have painful periods. Periods are supposed to be painful. Like, do I miss a week of work? No. So like the definition of what painful is so not defined. It's not like it's super tangible.
Or it's just accepted.
Yeah, it's
Women.
accepted because it's women. Or it's like, I only take 2 naproxen 3 times a day on the days that I get pain, but my girlfriend is debilitated on the floor, so I can't have endo. Like nobody's told me that before, and that I don't get it every cycle. So there's all this kind of questioning, and because so many women potentially have endometriosis, which is a factor that affects their fertility for many different reasons that you can comment on in a second, but that's a factor. And a lot of the times a person with pain then is trying to access care, but then they're given oral contraceptives to try to like help their pain and help them not get these kinds of horrible cycles. And then they're kind of covering up whatever that might have been that will affect them in the future. My reasoning is, well, I would want them to go see a gynecologist, or I want them to go see a professional like yourself to have something like a pelvic ultrasound done, because then you get to not identify endometriosis per se on an ultrasound because it's hard to see, but you might be able to see other things that help you identify what it wasn't, like if it wasn't endometriosis, or if you see the kinds of ovarian changes that are consistent with endometriosis, which happen in 10, 20, 30% of these women. So like the more you throw a net at it, the more you get to capture to see what's actually happening with this person. And then I sent everybody to like be my net that way. Tell me what you think about that.
That's brilliant. I think it's brilliant. Thanks. I think with these things, like number one, you need a healthcare provider that listens. Like, what's the best diagnostic tool for endometriosis? Listening. Listen to women. When someone says like, "Oh, I have to miss work,"
Good one. That's a good one. What's the best instrument? Your ear. Yeah, okay.
when you have to miss work because of your periods, like that's not normal. When you're in pain, like every day of the month, that's not normal. When you're throwing up from your periods, that's not normal. When you're like constantly bloated every day, like when you also have painful sex, painful bladder, like IBS, and your periods are like, that is not normal. So I think if we screen with our ears and then we look, because also, yes, you may see signs on the ovaries of endometriosis, but yeah, you're right. Like if someone is like, I have painful, heavy periods, you do want to rule out that they don't have like a large fibroid that's like encroaching in their uterine cavity. You want to make sure that, there's not, sometimes we can see like signs of the adenomyosis, which, in the same family as endo, that can be a clue. But, and also sometimes like even putting your, like doing a physical exam, like one of my, I think like love-hate relationships with the at-home HPV test is that I worry that it's the death of the pelvic exam. Is that like even just doing a pelvic exam with a woman and, there's so much you can learn just by like looking at someone's tissue. Like if someone's having pain, for example, painful sex, like, seeing what the health of the tissue looks like. Um, do they have pain under their cervix? Like, is the speculum painful? Like all these kinds of things we can do by actually like listening, but also doing some kind of assessment, either with an ultrasound or.
So every step of the way, is the speculum painful? Every step of the way, you're looking for clues as a sign of like, what's going on?
Yeah.
And kind of identify something.
Well, and then, I mean, this is a tangent, but vulvodynia is also something that is more common than we think. So like vulvovaginal pain, but the majority of women just don't talk to their healthcare. Like so often I am doing these things and I'm like, why does that hurt so much? And you're diagnosing someone, you can't really diagnose on the spot, but you're flagging it for them, ready to be like, that's not normal. Like you shouldn't have that much pain in that one location. Or things like I've had patients misdiagnosed for years with thinking that it's like menopause or perimenopause, like low estrogen vaginitis. But really they have like lichen sclerosis or a skin condition that they're just like no clue about. Their doctor's giving them vaginal estrogen, not looking. And then finally someone takes a look and you're realizing, oh, that's not what that is. This is what that is. So I think when we look at like a holistic women's exam, that in an ideal world, there'd be time to do all of these things.
And the age thing, I'm going to come back to that as like a clinician who'd want to know who are the people that I send for this kind of amazing, like listening, looking, talking, touching workup. Is it everybody?
I think it's anyone who has concerns at any age. If it's a concern for you, like talk to somebody. I think the most important group is people who maybe don't have a pathway to a family, but want a family. So someone who's like, I definitely want kids. I'm 29, 28. I don't have a relationship yet. Those are the people where it's like, come in for things like AMH, antral follicle count.
That was another good one. Don't have a pathway to a family, but want a family. Like these are some, you guys.
That's where a follicle count is really important. And that's where an AMH is important, because if you flag a low follicle count and you flag a low AMH, I'm not telling you that you're infertile. I'm not telling you that if you met your person a month later and you guys tried for a family, you would get pregnant on the first try.
Yeah.
It does not predict your ability to conceive naturally, but it does mean that if you have a low AMH, your runway for using IVF is potentially shorter. So it would mean that like if you want to freeze eggs, don't wait till you're 35. Do it at 30.
Okay, we circle back here without me prompting. AMH and antral follicle counts. What is AMH?
Okay. AMH, it's a blood test. It's a simple blood test, and you can do it at any point in the cycle. And it is going to give us an idea of what your ovarian reserve is, meaning like how many eggs do you have in reserve? And why it matters is because when you do something like IVF basically relies on collecting a lot of eggs from your body and then taking those eggs outside your body, fertilizing them, and creating embryos. But if they can't get a lot of eggs, then your chances of ending up with an embryo are less. So it's a numbers game with IVF. It just really is a tool that IVF doctors will use to predict your success with IVF and plan your IVF cycles. So especially with egg freezing, you need a lot of eggs because by the time you get the eggs, freeze the eggs, unthaw the eggs, fertilize the eggs, the numbers go down. So you have to start with a lot.
And AMH is, for the vast majority of people, anti-Mullerian hormone, it's called, is connected to your age.
For the majority of people, it's connected to your age. So yeah, that's the best predictor is your age. But what you want to find is outliers. So you want to find the late 20 or early 30-year-old who's told like, you're fine. Like everyone gets pregnant so easily in their 20s. You want to find those people where you go, okay, you'll probably maybe be fine. But if you don't have your pathway yet, like, and you would freeze eggs, like you should do it now and not wait till because a lot of people will be like, if I don't find someone by the time I'm 35, then I'll freeze my eggs. So they may want to do it sooner. Or
I mean, fertility clinics are booked. They're booked. They're like out.
They're very busy.
For a reason.
Yeah, or at least like have that conversation with a fertility dog. Say like, listen, I think you should go have this conversation and talk about it with an expert. It has a role in finding those people because if they would consider IVF, they may want to know that, it's probably maybe not going to be a great option for them beyond 35, or even like they say, like you can freeze your eggs up to 35, but maybe their runway's only till 32. Or say that you are in a relationship and you're thinking of a family, but you're like, listen, in an ideal world, we wouldn't have babies for 5 years. They may see that number and go, okay, we need to rethink things. We should start trying sooner just in case.
I see that all the time.
Yeah.
Judge me again on this one when I do. But like I'll ask female patients when they come in, because I do a lot of blood work on people. Like I literally am the one taking the blood. And as I'm drawing the blood, I'll be like, okay, you're here for your fatigue. But while you're here, do you want to know about this specific factor that might help you understand your fertility? It's called AMH. It's a simple test, $30-ish, I think. And then based on that, we can have a thoughtful conversation around what to do about that number. Because if it's really high as an outlier for your age, I question PCOS.
Yeah.
And then I'm like, oh, okay, I got something here. If it's just according to your age, if it matches your age, it'll be like, well, let's have a conversation about how it matches your age. And then if you're 37 and you have a desire to have a family, then know that it's matching your age, and we should have a conversation about what your likelihood is, then what you should be doing, and get further assessment if you want to. And then if it's lower than what's expected, then it's like, why is it okay? Then I have to refer out and then I normally send them to Dr. Shaw to be like, can you do a much fuller understanding of what's going on here for this person? Because they're not fitting the line, like they're not fitting their line.
Yeah. Yeah. That's exactly what it should be used for. I mean, I do it, but I also think it requires some detailed counseling because the number of women that come in with a low AMH and are devastated. I have so many patients I can think of in my head who had devastatingly low AMHs, but can conceive fine on their own because it takes one good egg. Your AMH will predict that kind of IVF success, but your age will better predict your egg quality. So it takes one good egg. So if you're 29 and you have a low AMH, you might not have a lot of runway of reserve, as in like each month you might not have a huge cohort that goes, but the quality is going to be better than a 38-year-old who has a good AMH. So quality is sort of the most important thing. Age is going to predict better than your AMH, your quality. So I think that that's the caveat of like, before I ever draw that blood for someone, I always say, explain very carefully like what the test is and what it isn't. This isn't predicting your fertility. It's predicting your timeline for IVF.
Yeah, try to do that. I usually say something like, if this is going to be something that we're going to discuss, we're going to have a very thoughtful conversation around all of this. Do you want me to do this now so that we get there and that we end up having that conversation the next time I talk to you? And I'll tell you something that sometimes happens and that I've seen in the medical world too. And let me know what you think about this. You know how like there's this whole idea that we're kind of diseasifying menopause, where we're just like, menopause has all these risks of conditions that come up later, and that we should probably consider screening women for all these different things in their 40s and 50s because their risks for these specific conditions like diabetes and heart attacks and strokes and fatty liver and all that kind of stuff increase. And people are like, well, stop diseasifying this natural time in a woman's life. And so we have to be very delicate around our conversations around that, to be like, we're not like, don't diseasify this natural experience, but do identify the things that do happen in that context and see what you can do to help this person. That might be hormone therapy or might be whatever, other kinds of things. Do you think, and I've had this said to me before, pre-screening women who have not tried to conceive yet is diseasifying fertility? I know. I just let's see.
It depends on how it's done. I think if it's done well and you're fully, I think, informing the patient of what it is and what it isn't, and you're doing it for the things we talked about, like to pre-screen for conditions that absolutely can have an impact on fertility. So like flagging these things that we've talked about, like PCOS and endometriosis. If you're diseasifying it by flagging those things, then I think that's a good thing.
Yeah, me too.
But I think if you're taking a low AMH and you're saying you're never going to get pregnant and you're labeling someone with infertility, if you could have like an equation that said like AMH does not equal infertility. As long as you're having a conversation, it's very clear, like, I will do this test for you, but if it comes back low, do not walk out of my office thinking that you had infertility. And I'll always tell stories about low AMH, including my own, where, I was told the exact words were, you should have done IVF yesterday based on your AMH.
Oh, I forgot this about you. If I knew this. Okay.
Yeah. Yeah. It wasn't true for me that I had any troubles with conceiving for 5 years as a 35-year-old until I had my first child at 40.
Like sort of forefront of your mind, like this is my reality.
This is my reality. And then for life reasons, it wasn't going to happen. And I had other things going on. And then when we decided we wanted a family at age 39 and I stopped the pill, I was like, okay, like we should start now because this might take forever and it may never happen. And we might need, IVF isn't on the table because my AMH is so low. And then, luckily things were fine. But
babies.
yeah, babies in my 40s, 2 in my 40s. So, yeah, I just think that is a very diseasifying in that way was very heavy for me to carry because no one ever told me, very clearly.
That's why you're so important for me, because then my female patients have somewhere to go to then have this personal and professional understanding, like lived experience understanding of the nuances, the extremes, the ability to explain things properly, so the women get this like reassurance if they need reassurance from a fear, or they're like, maybe, I don't know, like a fire is lit under them to be like, get on this, like, because maybe on the other end of it is they haven't been made aware that it needs to be taken more seriously for them, kind of thing. Either way, you get to be the one to like help them see where they are on that kind of spectrum.
Yeah. And more information is usually better as long as it's in the right context.
Okay, I hate the fact that we're using the words like circling back. I can't believe I've gone into corporate culture like this, but like we're circling back again. We're pinging the shit out of antral follicle count now. We talked about AMH as a blood test, as a potential way of understanding things about this body, not this body, but like the body. And then what's antral follicle count?
That's where we use the endovaginal ultrasound, and you look at an ovary and you literally scan through it and count how many antral follicles you see. So what happens every month, your ovary has, obviously we know that the eggs come from the ovary, and every month you ovulate one egg. But what happens to get to that one egg is that you have a cohort of what we call antral follicles that develop. And then at some point, one of them will be the dominant one, be ovulated, and the other ones will fade away.
Queen bee.
Yeah, one. And so what we try to do is capture what does your cohort look like every month. And so one of the things that I learned early on is when you tell someone, oh, your follicle count is 12, some people have actually thought that they had 12 more eggs left in their ovaries. It's not true. It's not like you have 12 more months of fertility.
People think that.
People have thought that before. I think, yeah, very clear. What it means, though, is at this stage, every month you're recruiting 12. Wow. So on an IVF cycle, the fertility doctors will have 12 to work with. So they have 12 follicles that they can potentially get 12 eggs from. So obviously in that context, the more antral follicles. So we try to measure them early in the cycle, because later in the cycle, if someone's ovulating, sometimes that can distort the image a bit. If you have one huge follicle developing, it's hard to see the little ones. So ideally, you're doing it between cycle day 2 and 4 in an ideal way. It doesn't have to be, but ideally. And you're just kind of scanning through and trying to count how many you see. And so in young people, it will be usually a lot. You'll be able to see 20 or so, almost too many to count. You're rising 79 accelerators going through you got lots. But what we're scanning for is if we look through and we're like, 1, 2, okay, that's not a lot there. And so you correlate that with their AMH to kind of advise on this runway we're talking about.
And the two go together.
They go together. I think antral follicle count is usually relied on as being a little bit more reliable than the AMH, but they usually correlate very well.
Okay.
It's very uncommon that they're discordant. And then the other thing we are doing is sometimes, obviously we're looking for large cysts or things that look like these chocolate cysts or endometriomas. But sometimes even within the follicles, we've talked about PCOS a bit, but a PCOS ovary will look large and have a lot of follicles, and they'll often be arranged around the periphery of the ovary, and so have this characteristic appearance. We call it a string of pearls, where they'll be sort of lining around the edge of the ovary. So those are the things that we're scanning for to be okay, yeah, that ovary looks what we want to be able to tell you is that there's lots of little follicles. your ovaries are normal size. There's no cyst that I can see, and it looks
Guys,
right here.
see how much information you can get out of this kind of thing? You're not getting this. I can tell you that you're not getting it. A very small fraction of you are. A minority of a majority who should be getting access to this kind of thing just isn't being spoken to about it. Like, look at how much you can find out. It's like a microscope inside your body that you can get to actually identify whether or not you might have this or this that play a role in your whole future. Like, that's how profound it is for me to be like, screen, like look through the window and screen everything, because the diseasifying thing that I was talking about before, I have like a lot of trouble with this, in that being a human being means to get diseases. We all get them. You know, a third of us will get cancer. Like, it's just part of the human experience. It's the nature of living. To pretend otherwise, that the majority of us aren't walking around with diseases, you're an ostrich. And therefore, we should be screening for the things that we know happen to the majority of us. And using tools like this gets you there. I don't think we should be afraid of it. Dr. Shaw said, thoughtfully and very considered, speak to what can this thing do to identify what, and then how are we going to speak to that and interpret that realistically and reasonably for this person in the context of what we have available to us to do about it. Like, it's so important that we understand there's limits to everything. And everybody wants this. Everybody wants you to say something like, everybody wants me to ask you something like, what's the best supplement you could take to make you have 100% more eggs? I mean, what's the number one dietary strategy you can take for a person to have regular cycles every month so that they know that they're ovulating? That doesn't exist, but everybody wants that now.
Yeah, it's so hard. It's the most frustrating thing. I feel like I frustrate people so much because I feel like the more you know about something, the more your answer is all this like, it depends. We don't know. It's so nuanced, and it should be. It should be. Again, like doing an AMH and a follicle count on someone who's 40, you're kind of like, well, you're 40, so I think you should start trying. Like, I don't think you should wait. And so you ask me like who the best people are. It's going to be more valuable the sooner you know that you can be flagged as potentially needing to do something sooner.
I have another very important question for you along this topic. A lot of people, weirdly, and this is as surprising over the last few years, when I refer them to you or somebody like you, that person offers fertility assessments like we've talked about, but then they also offer contraception. They're like, wait, you want me to go to talk to somebody about me having a baby who also inserts IUDs or who also offers birth control? Can you speak to that for a second? Because I have my own answer, but like, speak to that. Like, I'm like, it's all the same thing. I just like, it's all literally the same thing. It's the same thing. But like, you speak to that and why it's so important for you to also offer contraception.
I think it's all about offering choices and options. And it stems for me from a place of like, I'm a woman in this world and I've been a frequent flyer in like the OBGYN reproductive health world. And what I appreciate is having options. And I went on one of my mat leaves, and right before I went, I had a patient who really hated her IUD. And I was like, you should take this out so that we can get an idea. She wanted to have kids. And I was like, why don't you get your IUD out and then we can talk about, or talk to my local or whatever about, your fertility. Her cycles look, because she wasn't really getting periods and it was kind of a mess. I came back 6 months later and she's like, I can't find anyone to get my idea. Like, I'm on a wait list for a gynecologist for 6 months. And I was like, oh, I use this and it's literally a 5-minute process.
So you shouldn't be inserting them if you can't take them out. Honestly, that's my number one principle here is like, why are you inserting them if you can't reasonably take them out if something happens to this person?
And it's access, right? So for me, it's just providing choices. And I believe there's, again, like, how does it not go in line? You could do a full fertility assessment on someone, say, like, I think this is what's going on. This is what's going on with you. You don't want kids. You're 28 and you don't want kids for another 5 years. We can still work on your fertility. You can still work on your health. But contraception is an important part because an unwanted or unplanned pregnancy is a big deal. Or like we screened, we flagged you, we think you might have endometriosis, your painful periods aren't normal. Why don't you get a Mirena IUD so that we can stop the periods that are ruining your life? And maybe you get an IUD and you don't have heavy periods. Your 14 days of pain a month are managed better. So you can go to the gym regularly. You feel more like cooking because you can get out of bed. Your moods are better because you're not chronically like needing iron infusions. And you're using a Band-Aid, which this is where I sometimes struggle. Is like, I don't struggle. Actually, I feel very at peace with it. But how are IUDs naturopathic is that sometimes in naturopathic medicine, you have to use a Band-Aid so you can get at the root cause. And
Are you listening to this?
Mirenas are great Band-Aids, or any IUD is, for some people, a great Band-Aid, which means you can continue to work on the root cause. Because yesterday I had this conversation with someone. We've been trying to work on her endo, but we can't get anywhere because she's struggling so much with her periods. So we decided we're going to use the IUD to Band-Aid the periods, but we're going to work on the root cause. We're going to work on her gut health. We're going to work on her inflammation. We're going to work on like her sleep and all the other things that are going on in her life. But helping manage the periods is going to do that. And the thing about IUDs is that they're easily reversible. They're generally well tolerated. They don't have pituitary suppression. So unlike oral contraceptives, from a fertility perspective, they're great because you can usually still see a cycle. They don't affect your ovulation. And we can still sort of see what's happening from a cyclical perspective. And we expect a return to normal pretty quickly. So the fears around like suppressing my hormones don't really exist because they don't affect your pituitary.
The word Band-Aid is so important to talk about here because, like, what do Band-Aids do, people? They let the wound heal. They give it an opportunity for the wound to heal. So using tools that are Band-Aids can give you time. They can let whatever process is happening in your body actually normalize for a while so that you're not constantly fighting in a depleted state. This is so important. That's why I said to everybody, I was like, IUDs and fertility and counting eggs and doing blood tests for your AMH and birth control pills and implants, they're all the same thing. They're all female choice. They all offer you options that you should have access to because they exist to plan the whole journey and to walk you through the times where, you know what, this year, we're not going to do it because what you just said, it's too much. Like life is too much sometimes. And you're like, here's something that might take some of cutting the edge off. It might change your life for some time.
Yeah, they can be. They definitely can be life changing.
So many women are aware of, like, they freak out. They freak out. They come into my office and I say the letters I, U, and by the time I get to the letter D, they're running out the door. They're like, don't you come near me with that or don't refer me out for that because then this is every single time because my girlfriend had the worst experience ever. And then I say, let me send you to a trauma-informed, pain-conscious provider who is probably going to have you have a very different experience than whoever you are speaking about had. Please say something about that.
One, I think a part of me understands the run out the door is that for a lot of people, having a device in your body there's something about it that I can respect that might not feel right. Is that, yeah, okay, that's not for everyone. What I would say, and what I say to my patients who sometimes have fat as their initial reaction is like, they are very easy to take out. So coming out is like 1, 2, 3, gone. Like that easy. 1, 2, 3, out of your body. If you called me tomorrow and said, I hate this thing, I want it out of my body, I will squeeze you in, I will fit you in, it's out. Like something in your body that you don't want there should be out.
Oh, informed.
You should be able to have something, you shouldn't have to live with something in your body you don't like.
That's what I meant when I said earlier. You should not be inserting them if you are not going to be available to take it out.
Yeah.
Because what have you done? Like, you need to be available or have somebody available to take it out.
Yep. Because
you put something in somebody's body.
Yeah. That's what I would say. You know, I can fully, I think, acknowledge and empathize with people who doesn't, like, they just don't like the idea. That's okay. From a pain perspective, I think the first thing is to, again, recognize that women shouldn't have to suffer through pain. And so I think there's just this thing about like, IUDs are painful, suck it up, get through it. They don't have to be. Sometimes they are for some people, and that's a reality. But we have ways that we can help people. One is fully informing people about the process. So the more women know, the more comfortable they feel that they've had opportunities to ask all their questions, understand the process, know what to expect, feel comfortable with a provider. That in and of itself helps. Two, like doing these things in relaxed, non-rushed environments where you're not like shivering in a cold room under like a piece of like paper on your lap.
That actually happens.
Yeah. That's what it's like when you're often just like given a piece of paper. It said, take your pants off, and you're sitting there like
Like a diaper?
no, it's like a piece of
Like a dental thing?
paper. Yeah, like paper sheet. That's like a little square. And because of public funding, there's not as much money to these things, right? So in a private clinic, like we can use proper sheets, like we can have comfortable tables, like we can turn the heat up, like, and then we offer pain choices for people. So we do standard like anti-inflammatory pain medication. We offer cervical freezing for everybody, a cervical block. And then, the new thing that we offer is Penthrox, which is an inhaled analgesic and anti-anxiety medication for people who are really nervous and they have a lot of anxiety. Is that we can, it's a self-administered, basically almost like a inhaler, and people can self-administer to help get them through. So
it's the whistle you suck on your way to the ER if you're ever in pain. It's that thing. It's the green thing. But like offered also for pain for IUD insertions. How incredible. How progressive.
It's sort of a customized approach of like, what do you feel like you need? A lot of people decline and they say, I'll be just fine. But we at least offer all these things, and we help people decide how their experience, like as best we can, like how their experience will be. If people get partway through the insertion and they change their mind, like, okay, we're not doing this today. That's fine.
IUDs are good medicine. Like, I don't think women should be like as afraid of them as they are. And again, they're life-changing. And I think it's very important that we not villainize them because of the great percentage of women who have them inserted for non-contraceptive purposes.
Yeah.
For non-contraceptive purposes, for pain, heavy bleeding, they have fibroids. There's something else that makes their life just potentially even unmanageable, and it interferes with their day-to-day. IUDs are very, very good medicine.
Yeah. Perimenopause. For so many women, if you say, if we can make your periods pretty much go, you take a 47-year-old and say, like, we could maybe make you never have another period again. A lot of women will be like, yes, please. Yes, please.
And also, there's like a lot of understanding or misunderstanding that you need to have periods, that you need to be bleeding.
Oh,
No. Anyway, we're going to stop there on that little cliffhanger. You don't need to have periods, so you don't need to bleed. The list of questions very long, but we've gotten to our hour. I'm going to have Dr. Shaw back. I'm sure once I post this, there's going to be all kinds of questions in the comments of like, ask her this next time, please. Give me your questions, because we can do an Ask Me Anything on top of what we still have left to talk about. This is a many hours conversation, so I'm very thankful that Dr. Shaw is here for episode 1.
Thanks, Bobby.
Thanks for coming.
My pleasure.
Bye. Thank you so much for joining me today. I really had a great time, and I hope you did too. Please share this with a friend or a lot of friends, and leave me a review. It really helps promote this podcast. Thanks so much.